Okay, welcome everybody. I'm going to talk today about necrotizing enterocolitis. Through my lecture, I will talk about definition, incidence of necrotizing enterocolitis, the risk factors, pathophysiology, diagnosis and differential diagnosis, how to prevent necrotizing enterocolitis, management including both medical and surgical. Because nursing care is very important in NICU, I would like to dedicate a few slides about nursing care. Then we will talk about complications and prognosis. Necrotizing enterocolitis is defined as an ischemic and inflammatory necrosis of the bowel, primarily affecting premature neonates after the initiation of enteral feeding. Although incidence is different, but we need to know that predominantly it's a disorder of preterm infants. It can also occur in term infants, but many of these term infants, they do have pre-existing medical conditions. Overall, in very low birth weight babies, the incidence ranges from about 6 to 10%. Here it shows that the incidence of NIC and mortality are both inversely related to gestational or to birth weight. So the lower the birth weight, the higher risk of NIC and the higher mortality. You can see that, for example, for extreme low birth weight babies or babies ranging from 750 grams up to 1000 grams, the risk of NIC is about 9%, while the mortality from NIC can reach up to 29%, and you can see the figures for different birth weights up to 1500 grams. Now, what are the possible risk factors for NIC? Prematurity is almost a prerequisite. We said that it's a disease of prematures and rarely it can happen in term babies. Perinatal asphyxia is a very important risk factor. In case of absent or reversed in diastolic flow on the umbilical arterial Doppler antenatally, there might be an increment in the risk of necrotizing enterocolitis, in addition to no antenatal corticosteroids for the mother. If the baby is delivered or is having significant patent ductus arteriosus. Microbial colonization is a risk factor. Formula feeding is a very important risk factor. Circulatory instability, either due to septic shock or the PDA itself, is an important risk factor for necrotizing enterocolitis. Maternal cigarette smoking was associated with increased risk of necrotizing enterocolitis. The babies who are having congenital heart disease and babies with polycythemia and hyperviscosity syndromes. And then in case of blood transfusion, it's considered as a risk factor. Now, lots of these risk factors are still under discussion and studies are ongoing to decide whether these are genuine true risk factors or not. But in general, they are considered as risk factors for the meantime. So what happens in NIC? Actually, the theory behind the pathophysiology of necrotizing enterocolitis is that it's a multifactorial disease. We have several risk factors that interact to initiate initially a mucosal damage. So the common pathway starts from a mucosal damage via a final common pathway involving activation of an inflammatory cascade. In this slide, you will see that enteral feeding and prematurity are very important or prerequisites for the occurrence of NIC. As an important risk factor, circulatory instability in cases of PDA, for example, or primary infectious agents, bacteria, viruses, fungi, or inflammatory mediators. Both infection and inflammatory mediators will, in addition to the antibiotic use, which by itself can affect skin flora. So all these factors will come together to make a mucosal injury. And here you can see that a genetic predisposition is now recognized as one of the risk factors through a mechanism, the discussion of which is or might be beyond the time limit of this lecture. So once we have mucosal damage, this will result in invasion of the bowel wall by gas-forming or gas-producing bacteria, resulting in intramural gas accumulation, which we call pneumatosis intestinalis. This then may progress to transmural necrosis or gangrene of the bowel wall, and finally to perforation and peritonitis. If you have a baby with a presentation that is going with necrotizing enterocolitis, do not forget to keep in mind other differential diagnoses. This could be sepsis with ileus, or it could be bowel obstruction. Volvulus can present the same way, malrotation. Spontaneous intestinal perforation is a very important thing to differentiate, and usually it happens even before starting feeding and without pre-existing pneumatosis intestinalis. And usually it occurs early in the disease of preterm babies. Systemic candidiasis can be a differential diagnosis. And lastly, food protein-induced enterocolitis syndrome. So how does necrotizing enterocolitis present? The presentation actually is variable. Up to 30% of these cases will present as mild symptoms, while 7% will present as fulminant neck, and the other percent will be for a ranging between mild and fulminant presentation. Now, as a clinical presentation, we can divide it into three parts: the early clinical presentation, non-specific signs, and then specific signs. Early clinical presentation can include feeding intolerance, increased gastric residuals, and blood in the stool, while non-specific signs can include symptoms and signs of neonatal sepsis, which may include apnea, bradycardia, temperature instability, hypotension, and circulatory shock. Specific abdominal signs might include abdominal distension, as you can see in the figure or in the picture here. It can detect tenderness, abdominal wall discoloration, emesis, and bilious drainage from the nasogastric tube. Now, clinically and radiologically, as you know, we classify necrotizing enterocolitis into three stages with subdivision to A and B for the three stages. In general, we can say that stage 1 is suspected neck, stage 2 is definite neck, and stage 3 is advanced or complicated neck. We will not go into details of this classification, but usually in stage 1, X-rays will be normal with some changes like dilatation or ileus in the X-rays, while in stage 2 there will be definite radiological findings like pneumatosis intestinalis in addition to the abdominal signs or clinical signs, while in stage 3 we are talking about advanced or complicated neck when we have pneumoperitoneum, or like stage 2 with definite ascites. Now, how to confirm the diagnosis of necrotizing enterocolitis, or what are the laboratory studies that suggest that this baby is having necrotizing enterocolitis? Now, this is a very important slide, and it aims to remind you about the laboratory findings in case of neck. CBC will or might show anemia, might show leukopenia or leukocytosis and thrombocytopenia. Blood film can show evidence of hemolysis and toxic changes like spherocytes, evacuation, and toxic granulation of neutrophils, cell fragments, and polychromatic cells. C-reactive protein as a stat test may not be helpful, but serial measures for CRP are very important for both diagnostic and prognostic purposes. So when a baby with neck is showing decrease in the C-reactive protein, this might be a sign of improvement in the clinical condition of the baby. Electrolytes may show hypo or hypernatremia in addition to hyperkalemia. Blood culture and stool culture should be requested, of course, and we will start antibiotics. As we said, that neck is a multifactorial disease and blood culture might be positive. Now, In the literature, it ranges from about 10 to 30% of cases of NIC will have positive blood culture. Blood gas is important here, and we most of the time will see metabolic acidosis, although it can be a combined acidosis in addition to raised lactate if available in your institution. Coagulation studies are important in case of NIC because it may show coagulopathy with high PT-BTT in addition to fibrinogen degradation product or indicate a picture of DIC. Now we'll talk about imaging studies. We have the flat radiographs or the decubitus films, as we will mention, in addition to ultrasonography. For the flat radiographs, we will present or we'll talk about that it can present a picture supportive of NIC or it can confirm NIC. For picture supportive of NIC in X-ray, we can see abnormal bowel gas pattern, we can see thick bowel wall, loss of the normal polygonal pattern, we will explain this later, ileus or bowel wall edema with thumb printing, fixed sentinel loop of the bowel or areas suspicious of pneumatosis intestinalis. So these are the early radiological signs that we need to keep in mind in cases that we suspect NIC. So what are the confirmatory cases of NIC? When you have, of course, pneumatosis intestinalis and intrahepatic portal venous gas. In addition, of course, to the free gas, as we will see later. So this is what's called polygonal gas shape, and this X-ray is reassuring. You can see how the X-ray, the abdominal gas looks, and this is reassuring. It's called polygonal. Thumb printing, as you can see here, is one of the non-specific signs of necrotizing enterocolitis. Pneumatosis intestinalis occurs usually when hydrogen gas is becoming evident in the bowel wall. Hydrogen is produced by the metabolism of bacteria within the bowel wall. So it gives the picture of pneumatosis intestinalis. We have two patterns of pneumatosis intestinalis, either the linear streaking pattern or the bubbly pattern. Here you can see in both slides the linear streaking pattern, how it looks like. You can see linear pneumatosis intestinalis here, everywhere, and you can see it also here. These are clear findings of linear streaking pattern. While the bubbly pattern appears here like retained meconium, or it is actually a less specific sign, but still you can see here in the right lower abdomen, it is a bubbly appearance of pneumatosis intestinalis. The second radiological study is the lateral decubitus and the cross-table lateral studies of the abdomen, and usually we do these studies looking for free air. The third study is the abdominal sonography. We know that the ultrasonography is an operator-dependent study, but it was found that it is a very important study, especially in the presence of non-specific clinical and radiological findings. It can detect intermittent gas bubbles in the liver parenchyma and the portal venous system. In addition to the benefit of the color Doppler ultrasound, which is useful in detecting the bowel necrosis and perfusion. Ultrasound can show bowel wall thickening. It can show alteration of the vascular state. For example, if we have a hypovascular state indicating a viable but engorged in early stages of NIC, or hypovascular, which is indicating infarction in the later stage. It can show, the ultrasound can show also intramural gas manifesting as high echo foci within the bowel wall. Or it can also show free fluid, especially with the echogenic debris, which is suspicious of perforation. You can see here You can see the hyperechoic area indicating intramural gas. In this case, you can see the portal venous gas, which also appears as hyperechoic within the liver parenchyma. Now, this is a schematic presentation in addition to Doppler findings in case of normal going to the abnormal pattern of neck, or in other words, the sequence of changes in bowel wall thickness and perfusion in cases of neck. So we're talking about both thickness and perfusion. In the first one, you can see how normally looks. This is a schematic presentation of what it looks like in reality. You can see here how the bowel wall looks and the vascularity. In this stage, you can see that the vascularity is increasing. The bowel wall thickness is increasing. Here, more or the thickness is the same, but the vascularity started to decrease. Here we started to lose the thickness, but the vascularity is small, almost sparse, and in the advanced stage you can see that the bowel wall thickness is very narrow, in addition to the absence of vascularity, which is a bad or late sign. So you can see how informative the ultrasound can be in cases of neck. Last thing in the studies, it can be the mesenteric oxygen saturation, which can help as early detection and real-time non-invasive monitoring for decreased bowel perfusion. So we finished the talk about how to diagnose neck. I know there is a lot of talk in the literature about new markers, but until now there is no standard marker for necrotizing enterocolitis, but this can come in the near future. Prevention is better than cure, and this applies to much extent to cases of neck. This disease can be to some extent prevented by some measures. The first and important one, and confirmed in all literature, is the use of human milk or expressed human milk, either maternal or donor human milk. Use of feeding protocols was associated with decreased incidence of neck in most of the studies, while some studies did not show this benefit. The use of probiotics and prebiotics is questionable, although most of the literature now favors the use of probiotics. Avoidance prolonged empiric antibiotic use, and this one is really important. So when you have a baby who's admitted for suspected sepsis, case of RTS, you started antibiotics as possible early neonatal sepsis, you have negative culture, the baby's clinical condition improves. It's ideal in this time to stop antibiotics, because the prolonged use of antibiotics is not without penalty. You are not protecting your baby, you are affecting his gut, in addition to increase the resistance to antibiotics. So wise or timely wise management of the antibiotics is very important here, and the stopping antibiotics in the proper time will help your baby survive without neck. Antenatal steroids has a preventive effect on neck, and the management of PDA here is totally questionable, because it is not confirmed that either medical or surgical closure may decrease the incidence of neck, but still this one is under study in the literature. This is a very important study which shows the different modalities of preventive measures, and it has been classified into 4 categories. The first category, as you can see, which has evidence of efficacy and safety, and this includes 2 preventive measures: breast milk feeding and non-aggressive enteral feeding. The second category includes evidence of efficacy but questionable safety, which includes enteral aminoglycosides, probiotics, glucocorticoids, and arginine. With the third category includes evidence of efficacy in animal models but not in humans, which includes anti-cytokines and growth factors. The fourth quality category includes proposed efficacy but lacking strong evidence, and this one includes prebiotics, microbial components, and toll-like receptor agonists, and glutamine N3 fatty acids. Okay, the general guidelines of medical management in cases of NIC should include the following factors or the following actions. The baby should be kept in PO, and this is different from one stage to another. For example, in stage 1, you can keep him in PO for 3 days, in stage 2 for 7 to 10 days, while in stage 3, you may need to discuss with the surgeon before deciding the timing of feeding for the baby. Total parenteral nutrition should be provided in order to make sure that your baby is not deprived from the essential nutrients. Gastric decompression through orogastric tube is very important. Long line, when your baby is stable and your blood cultures are negative, it's better to insert PICC line or whatever long line possible. Pain relief, and consider morphine or dimorphine infusion. These babies need close monitoring. They need monitoring of gastrointestinal bleeding, which can be massive. Respiratory support will depend depend on the case. Circulatory support, of course, is very important. These babies may develop hypotension due to shock or hypovolemia. Strict fluid intake and output monitoring, laboratory monitoring, including electrolytes, complete blood count, with measuring the platelet count, which is very important and not uncommonly to have thrombocytopenia. Antibiotic therapy is a must for these cases, and again, it depends on the stage of NIC. Monitoring for DIC, in addition to imaging studies, which might need to be repeated frequently. Why do we need frequent repetition for the imaging studies? Let's take a baby with suspected NIC. We are looking for signs of confirmatory NIC on radiographs. Actually, pneumatosis intestinalis is not a fixed abnormality, and it comes, it goes. So if you depend on, let's say, once daily radiological studies, you might not detect the intramural gas. Some literature recommends every 6 to 8 hours repeating the studies looking for pneumatosis intestinalis. If you already have these findings, you need to exclude complications, and the most important of which is the pneumoperitoneum. So you need to repeat X-rays in order to make sure that your baby did not go into these complications. And of course, we need to inform the surgeon for any baby who's having stage 2 necrotizing enterocolitis. In general, medical management of these babies for stage 1 include, as we said, antibiotics for 3 days, keeping NPO for 3 days. If blood cultures are negative, baby is improving, you can refeed him after 3 days. For stage 2, either A and B, you need to give antibiotics for a longer period. For 2A, you may need to give antibiotics for 7 to 10 days and keep the baby on PO for the same period. For 2B, you may need to give antibiotics for 14 days. In stage 3A, you need, in addition to what's mentioned to stage 2B, you need fluid restriction, inotropic and ventilatory support, in addition to possibility of blood products. While in 3B, you need to consider surgery and to discuss with the surgeon the timing of NPO. The only absolute indication for surgical intervention is the presence of pneumoperitoneum, but many cases do require surgery before development of pneumoperitoneum. For example, if you have portal venous gas, some cases may indicate the need for surgical intervention. Abdominal wall edema and cellulitis, which may indicate peritonitis, is another relative indication for surgical management. Fixed dilated intestinal segment by X-ray or sentinel lobe is an indication for surgical intervention. Tender abdominal mass is another relative indication for surgical management, and clinical deterioration refractory to medical management. What are the types of surgery? We have exploratory laparotomy and peritoneal drainage placement. Now, a lot of talk also again to discuss which one is better. Actually, the studies showed no preferences or no advantages for one procedure over the other one. Usually for tiny babies or extreme low birth weight babies who are less than 1 kilogram, we prefer the peritoneal drainage, while babies of 2 kilograms, we tend toward exploratory laparotomy, especially if the baby is relatively stable. Now the dilemma is for babies who are between 1 to 2 kilograms. Again, this depends on the surgery preferences, on the competency of the surgeon at your institution, on the local guidelines, and any update on this issue. Now we will talk about a very important issue regarding the nursing rule in these cases. We will present around 4 or 5 slides about the nursing rule. The first one is about monitoring abdominal distension and prevention of perforation by keeping the baby in PO, by passing size 8 French NGT and place on free drainage, by aspirating the nasogastric tube hourly and observe for air, blood, and bile, by monitoring abdominal girth twice daily. The abdomen should be kept seen at all times. The second important aspect is maintaining adequate hydration and nutrition. You need to administer total parenteral nutrition as ordered, of course, and you need to observe for hypo or hyperglycemia. You need to check dextrostick 6 to 8 hourly according to the baby's situation. Look for edema due to hypoproteinemia. Look for jaundice due to peristalsis. Even check the electrolytes for possible imbalance. Look for dry skin for possible zinc deficiency. Monitor the cardiac respiratory complications due to fatty deposits, and also look for the IV site for possible infiltration or phlebitis. The third aspect is the monitor of elimination. Here we are talking about ensuring adequate urine output more than 1 ml per kg per hour, and the use of urine bag or weigh the nappies. Now you need also to monitor urine dipstick every 4 to 6 hours, and in addition to the monitoring of stools for frequency, consistency, color, odor and amount, and the presence of occult blood. Any abnormality you have to inform your physician. Monitoring of vital signs, of course, this is important in addition to the usual pattern. Here you need to observe for signs of anemia and shock. The condition can deteriorate extremely quickly. You need to monitor 2-hourly temperature, pulse, respiration, blood pressure, oxygen saturation, perfusion, color, and activity. Inotropes may be administered as ordered by physicians for hypotension, and you need to check hemoglobin as ordered. You need to observe for and treat pain. This is very important. So you need to use minimal handling and nesting technique to provide comfort. Shield from light and sound. Use non-nutritive sucking as comfort measures. Observe for signs of pain like crying, especially when handling, tachycardia, tachypnea, and high blood pressure. And you need to administer analgesia as prescribed. You need to prepare for surgery or for transfer if you do not have a pediatric surgeon at your institution. So you need to ensure obtaining informed consent from parents, and you need to prepare baby for surgery as ordered by anesthetist and stabilize the baby prior to transfer. Then you need to support and reassure parents by prior to discharge. You need to ensure parents are educated and confident in feeding. You need to educate them about complications that may arise, and you need to provide support systems and a way to follow up appointments. So what are the possible complications of necrotizing enterocolitis? Recurrence rate in about 10% of cases. Development of strictures can occur in about 10% of non-surgical cases. Surgical cases, of course, they have different figures. Short bowel syndrome is devastating and bad, let's say, complication of necrotizing enterocolitis, and the outcome is guarded in these cases. Parenteral nutrition associated liver disease is one of the recognized complications. In addition, of course, to infection associated with the prolonged TPN use, and especially in cases of surgical neck neurodevelopmental delay. Prognosis in general for infants with neck, they have an overall mortality of 12.5%. If neck with perforation, it is associated with mortality of up to 20 to 40%. Infants with surgical neck also, in addition to mortality, they are at higher risk of significant growth delay and adverse neurodevelopmental outcomes. These are my references, and thank you so much.